So next is ruptured abdominal aortic aneurysm v21. 70-year-old male smoker with a non-abdominal aortic aneurysm presents with a 2-hour history of sudden onset severe back pain and lower abdominal discomfort. The patient was alert and his blood pressure on admission was 90/68, pulse 100. He had abdominal tenderness with apparent pulsatile abdominal mass, and he had a full complement of palpable peripheral pulses. Emergencies contrast CT showed a rupture of 6.5 cm infrarenal AAA with anatomy suitable for endovascular aortic aneurysm repair. His baseline creatinine was 178. There was no other significant history of note. The patient is keen for repair. How would you decide to repair this patient ruptured AAA? The decision to treat with the open repair or surgical repair is based on expertise, availability of endovascular hypersuit, and patient comorbidities, previous history of abdominal surgery. Patient who are relatively young and fit with few comorbidities will benefit from an open repair. Patient choice of financial constraints. The improved trial involved 613 eligible patients with the clinical diagnosis of ruptured AAA for 30 vascular centers recruited from 2009 to 2013. 368 patients randomized to EVAR, and the primary outcome measure were 30-day mortality and 24-hour in-hospital mortality, cost, time and place of the discharge as necessary outcomes. There was no difference in 30-day mortality between two groups. Although the more patients in EVAR were also discharged directly home, women may benefit more than men from endovascular strategy. All at 3 years, an endovascular repair for suspected AAA was associated with survival advantage, gaining in quality of life and reduced cost. These findings support the increasing use of endovascular strategy with wider availability of emergency endovascular repair. The rate of mid-term re-interventions after rupture is high, more than the double that alter the elective EVAR and open repair, suggesting that need for bespoke surveillance protocols. Amputations are much less common in patients treated by EVAR than in those treated by open repair. You open the abdomen of a suspected rupture AAA and realize that the AAA is juxtarenal. And how would you apply a supraciliac clamp in the setting to gain proximal control? As in insert NG to the stomach, NG can be palpated and within the esophagus, maybe the subsequent steps. Make sure you have good assistance. The left liver is mobilized by division of the triangular ligaments and retracted to the right, and the lesser omentum is open to express the abdominal pair to exposure of abdominal surface of the crura. The right crust is split longitudinally to expose the sides of the front of the aorta. The esophagus can be retracted away from the aorta, which direct vein and plasma of the palpation of the usually weak aortic pulse. The supraciliac clamp can be applied. The infrarenal abdominal sac can then be dissected out and taking care not to damage the renal vein. Once this is done, the comb can be moved, achieved to be applied in the infrarenal neck to minimize the bowel and renal ischemic time. How do you control the bleeding during an endovascular repair? So the most common femoral arteries are assessed by the local anesthesia with anesthetist ready and all poised for intubation, and general anesthesia with cricoid pressure in the prevent regurgitation of the stomach. A guide wire is passed up into the aorta, the control femoral artery. Another guide wire is passed excluded for a further stiff A guide wire is passed through this little guide wire, and 18 French long sheath is placed. So anyhow, through both femoral arteries they can access, and they can deploy the graft that can do the job. On day 3, after assuming successful emergency EVAR, the ICU will inform that you are worried about the development of abdominal compartment syndrome. How will you manage this patient? Abdominal compartment syndrome occurs when blood within the patellar cavity will space accumulates in such a large volume that the abdominal wall compliance threshold is crossed and the abdomen can no longer stretch. This leads to a period of rapid rise in the pressure within the abdomen. If the pressure continues to rise to 20 mm per organs begin to fail, including renal failure, hypertension, bowel ischemia, splinting of diaphragm, and difficulty in ventilation. Management will be maximum organ support. ICU decompressive laparotomy to remove the extra blood and also leave the laparostomy open. For example, proximal and mesh closure. Failure to relieve the pressure is always uniformly fatal, and surgical intervention has been shown to impress. The development of compartment system offered emergency is often multifactorial. Coagulopathy. Some surgeons advocate pain inspection of post-EVAR aneurysm sac in order to light lumbar arteries or other bleeding vessels to close the sac. The main worry is an indication of the stent graft and the patient needs to be covered with antibiotics. Thank you.